Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session.
Thank you, Maren. It's good to be with you this afternoon, and hopefully you've enjoyed the sponsor break and some of the morning sessions. I'm going to bring to the stage with me Leanne Candura. Session, and I especially want to recognize our sponsor for this session, the California Healthcare Foundation, and thank them for their sponsorship. Leanne, are you ready to go?
I'm ready.
All right, let's go ahead and bring the panelists to the stage. If you want to go ahead and introduce people as they appear, that would be great.
Great. Good afternoon, and thank you Norm. I have the pleasure of moderating this panel session on non-claims-based payments, lessons learned, and data collection standards, definitions, and reporting. So hope everyone is in the right place. That's what we're going to be talking about this afternoon. So I want to welcome our panelists in a moment, but I just want to also give a brief intro of the goal for collecting non-claims-based or alternative payment models is to track the transition from fee-for-service to value-based reimbursement, and ultimately to evaluate the impact of these payment models on quality and cost of care. This is especially true when trying to understand the investments being made in primary care, and with the growing number of payment models, many states are lacking the ability to track spending and the number of patients receiving care under these models. There is also a lack of common definitions about what are considered non-claims-based payments, which creates issues as more states attempt to collect these data from the same healthcare payers. Several states have been paving the way in collecting and reporting these data, while others are starting the process and looking to leverage standards and lessons from other states. This panel includes representatives from 3 states who are along the spectrum of collecting and reporting on non-claims-based payments. Audience members will hear about the variation and commonalities in their approaches. The format of today's panel will start with an introduction of all the panelists, followed by each panelist setting the stage for where their state is at in the collection of these data, followed by a set of curated questions to better understand the resource investments in these efforts, the data quality, and then highlighting some use cases. For audience members, please feel free to utilize the chat feature throughout the session. We'll probably try to intersperse some questions along the way, but there'll also be plenty of time at the end. Now to welcome our panelists, Zachary Goldman is a healthcare economist for the Oregon Health Authority, where he focuses on issues at the intersection of healthcare and economics, which includes cost trends, market dynamics, alternative payment methodologies, value-based payments, and more. Prior to joining OHA, he was a senior policy specialist that covered California and helped launch the state-based health insurance marketplace. Next up is Julie Trimrooli. She's an intake quality and policy analyst with the Center for Improving Value in Healthcare, which is in Colorado. Julia's experience and expertise spans from working directly with data submitters to ensure their submissions to the Colorado APCD are timely, accurate, and of high quality, to then analyzing those data to support a variety of custom public and legislative efforts. For today's session, Julia will be talking about her experience leading the effort to collect alternative payment model data in Colorado. And finally, we're welcoming Karynlee Harrington, who is the Executive Director of the Maine Quality Forum, the state organization responsible for improving healthcare quality in the state of Maine, and also the Executive Director of the Maine Health Data Organization, the state's healthcare data center. In addition, she also serves on the NAUTO board and is the board chair. Prior to joining state government, Karynlee served as the Vice President of Sales and Customer Support for Cigna Healthcare of Maine and New Hampshire. So welcome, panelists. So I'll kick off the panel with some initial remarks from each panelist to kind of lay the groundwork for today's conversation. Zachary, would you like to start with providing some background on Oregon's experience?
Yeah, sure. Thanks for having me here. So Oregon began collecting the payment arrangement file, which shows both claims and non-claim spending data. We collected it from commercial carriers back in 2017. And it was really as part of our entire all-payer, all-claims program, so our APCD here in Oregon. Shortly thereafter, though, we required these data from our coordinated care organizations, which are Oregon's Medicaid managed care. So we've been doing this since 2017. We went down this path because alternative payment methodologies, even back then, they were becoming more and more popular. And particularly, quality incentive payments have been baked into our Medicaid program and the coordinated care model for a long time, for many, many years. So we really wanted to leverage data to understand how those payments were getting to providers. Since 2017, though, the landscape has changed a lot, right? Alternative payment methodologies, or value-based payments, as we call them here in Oregon, they're even more popular now. The Oregon Health Authority now requires our coordinated care organizations to pay a growing % of their spending in the form of value-based payments year over year, all the way through 2024. Moreover, Oregon's Public Employee Benefits Board and Oregon Educators Benefits Board, so state employees and our educators, they are contemplating requiring more value-based payments in future years. And all the carriers in the state and many health systems actually very recently signed a voluntary value-based payment compact to advance the prevalence of value-based payments here in the state. So there's a lot going on in recent years. And I think we were lucky to kind of get in on that ground level. I'll stop there. I have a lot more, but I'll stop there because I want to hear from others.
Great, thank you, Zachary. Quite a history in Oregon. So next we're gonna move to Colorado. Julia, would you like to provide some background on how this started in Colorado?
Yes, definitely. So it's interesting to hear Zachary's summary of the collection in Oregon because it's very similar in Colorado, just a couple years delayed. So we started collecting alternative payment model files from carriers in 2019. That was our first year of collection. And we drew quite a lot of inspiration from Oregon, the model that Oregon had used at that time. And since then, it's evolved a little bit, and we'll get into that in a second. But yeah, we've used those files primarily for to satisfy the requirements of regulations with the Division of Insurance in Colorado to start measuring primary care spend. As many people know, if you're only looking at primary care spend on total claims-based payments, you're really missing a huge chunk of money that gets distributed to primary care providers on value-based payments and alternative payment models. So the healthcare department in Colorado and quite a few other folks really realized a few years ago how important it was to collect this information. And we knew there was just limitations to the claims-based data in the Colorado APCD. So we started collecting it, like I said, 2019. And we've really dived into the whole process of collection and really learning so much about the different carriers across the state, really. And we've, of course, informed ourselves from other states as well. But we've really enjoyed, we've learned so much through this process. And like I said, like Zachary said, there's a lot more to talk about, but I think that probably sums it up for the most part.
Yes, that's a great way to set the stage. And so speaking of setting the stage, hi, Karynlee. Can you speak a little bit about how Maine's been doing and where you're at with the non-claims-based payment data collection?
So good afternoon, everybody. And similar to what Zachary and Julia described, I think Maine's rationale for wanting to collect this data is primarily because of legislation that passed a couple of years ago that required one of our state agencies to report on the amount of primary care spending in the state of Maine annually, and to include the different methodologies that payers are using to pay primary care. So that agency, which I also work with, noted in its first annual report that, and let me just say, we're supposed to use the data from Maine's all-payer claim database, which is the Maine Health Data Organization in the state of Maine. And so we had noted in our first report that, as Julia just pointed out, not having a big part of how primary care is paid for is the investment that payers are making in the state of Maine. So we encourage the Maine Health Data Organization's board to consider adopting a rule that would require payers to submit non-claims-based payments for the one use case of that annual report. And it's taken some time to get there. And I'm happy to report that with discussion with Julia and Zach and others that have gone before us, as well as looking at the ballot report that the folks from Millbank had supported, that a structure for collecting this kind of data. That helped us with our partner HSRI to come up with a proposed rule that we will be hearing from the public on. Actually, wait a second, we just did. I'm sorry. We actually just did our public hearing last week, sorry. And interestingly enough, we did not get any public comments from all the payers that attended that meeting. And we can talk more about that as I think this session goes on, but that's sort of the history and where we're at. And we've taken a lot of the lessons learned from you guys and look forward to our next step in the process of collecting this data.
Great, thanks, Karynlee. So yeah, and then speaking about lessons learned, as we just heard, Zachary, Oregon was the first state to really start collecting these data in a standard way. And I remember being an audience member 4 or 5 years ago at NATO and listening to a presentation from your colleague talking about all the challenges they had in collecting these data and wondering if the effort was worth the return. And fast forward, and now your state is the one we're all looking at when trying to create a standard. Can you tell us more about what some of those early stages were? And as Karynlee said, we didn't get any comments in Maine for when this rule was put forward. Tell us about what that looked like when you initially started.
Sure, yeah, happy to. So I think that the effort is definitely worth the return, but there is effort. And let me talk a little bit about that. So standing up these new data, they're not necessarily easy. They're very different than what we're all used to. The claim processing infrastructure is well established. It's been going on for decades now. It flows fairly well, but this is really new. So we had to build, file specifications, validation rules, obviously. We even hosted a number of office hours in the first handful of years, so data submitters can call in with random questions. We continue to write and update frequently asked questions documents. All of these require staff resources. So let's just be really clear about that. There are some demands on staff time to both stand up and manage and administer this type of data collection. And it's also really important to recognize and acknowledge the demand on data submitters' side, right? This is new. I heard from multiple data submitters that for the first time it required folks from the analytics team to collaborate with folks from contract management team to also collaborate with folks from kind of finance accounting team. And in some cases, they didn't even know who those people were, right? They just kind of did their work and they did it well. But that was new for a lot of data submitters, just to create those relationships. And then lastly, compiling all these data was and largely still is a manual process. Sure, you can write some scripts for it, and some SQL or SAS coding, whatever you're using, but there oftentimes are some kind of manual piece to it. So there is some lifting to be had. But that said, look at the value of the data. And in fact, just last week, for the first time, Oregon Health Authority published carrier-specific data showing what % of payments were in which HCP land category, which value-based payment category. And I'll share that link via text as we're wrapping up our panel. It's really exciting.
Thanks so much, Zachary. Your reporting that you recently released is such a huge asset to the field looking to those who are looking to start collecting these data, what you can show from it. So I know all the audience members will look for that link. So Julia, let's move on to you for a moment. So Colorado started collecting these data a few years after Oregon. I think you've just begun your third data collection cycle. How did when you started, how did that differ from what Oregon had, and how much did you rely on their standard, and then how did you change it?
Wonderful question. And you're right. Today, if there's any payers listening who operate in Colorado, the files are due today. So make sure those are in. We're looking, we're paying attention. But yeah, that first year when we started collecting, when we created the specifications, it was honestly as close to a straight copy and paste of Oregon specifications as you can get, because we really didn't quite know what we were getting ourselves into. We even had references to Oregon legislation in our specifications. So that was a bit of an oversight, but the whole point of it was that we were really looking to their specifications, and we learned a lot that first year. I think one of the main differences that we had to make the next year, or I guess the main changes that we had to make the next year, was this concept of contract. When you're trying to eliminate any noise with other states, so especially for these large national carriers, what you have to kind of decide on how you're gonna define the geography. So for Colorado, we wanted to figure out, how are we gonna define this? And what we started with was using the inspiration from Oregon to talk about contract situs. So for example, if you're an employer in the state of Colorado, but your employees maybe live in Wyoming or Utah, the Wyoming and Utah member data will be included in the submission to Colorado. And that ended up being kind of a problem for us because we didn't realize how much of a difference when we were on Zachary's calendar quite a lot that first year, and we were learning a lot about how in Oregon that was really important based on the stakeholder feedback. But in Colorado, we just have a different landscape. There's a huge difference between situs members and who are receiving care versus the actual Colorado residents. So that was a really important change that we had to make the following year so we could actually look at care that was getting received in Colorado for Colorado residents. So that was one big example. And the other one was, I think, the timing when we took those specifications in terms of the payment arrangement categorization. Zachary mentioned the HCP LAN, the Healthcare Payment Learning and Action Network. We moved to that, and I think it was last year was the first year that we moved to that because we didn't really have a way to tell carriers exactly how to categorize their payment arrangements, and that's turned into quite a resource suck. We've learned a lot, and it's been worth it, but we decided that because Oregon had used some homegrown codes, if it's capitation, then just put it in the capitation category, for example. So we ended up moving to the HCP LAN mostly because they had all these resources on, what is category 1, what is not category 2. And if you're familiar, you might understand what that means. If not, that might sound foreign to you. But that was another difference that we had to make. But other than that, the actual structure of the files has really worked out for us in terms of, especially for the primary care versus total spend. The structure of the files really lends itself to making a lot of sense. What we've done, though, as well, is we've expanded the file, especially for this year. This is the first year we're collecting it, and we're so excited. And we're collecting more qualitative data from the carriers. So we have this contract supplement that we're collecting where the carriers, and it's a lot, and we don't use it for reporting purposes. It's just for us to make sure we truly understand what's coming through from the carriers and making sure that they're submitting the file in the way that we expect, because it's a really complicated file submission when you really get down into the details. So it's been a way for us to understand a lot more about these contracts so we can give the carriers better instruction, really, and better guidance to be collecting as good of data as possible.
Great. Thank you, Julia and Zachary, for providing the background on your experience. Now, Karynlee, Maine, we just have a new standard approved. So tell me about how what you've learned through talking with Zachary and Julia and all the work that became before this, how that helped inform the standard that you put forth in Maine. I think you're muted.
Sorry about that. Just to be clear, in case there are payers listening to this, we've gone through the first phase of the process, which is a public hearing. And now that the stakeholders have a period of time to submit comments in writing. And then we'll respond to those comments and present those to our board and perhaps make some revisions to what we've based on the comments. It'll be interesting to see if we do get written. Generally, we receive verbal comments followed up by written, but as I mentioned, we did not really receive any significant verbal comments during the hearing. So if all goes as planned, the MHDO Board of Directors adopt a version of what we've proposed, exactly what we've proposed, before the end of this calendar year. And we'll start collecting the data as described in the rule next year. And I think what, is for me, talking with Julia and Zach and others, that it's exactly what Julia said, and I think alluded to this. There is a level of complexity in all of this, in defining what these data elements are and how you structure it, you collect it, the administrative burden on the payers, the administrative burden for the plans that are taking this data in. This is all new for us. We're not really quite sure what we're looking at, whether it's accurate or not. So it's new all around. And I think I think two things. One, it really, and at least in my mind, is a reason for why we need to get all of the experts in a room and we need to figure out a national standard. And I think that's going to come later in what you're asking us, maybe, Leanne. But I think that's so important because there are questions that we did not, or issues that we decided not to take on in our rule. We took a very minimalistic approach and said, let's just collect exactly what we need, only what we need for this particular report, where we need to indicate the percent of investment in primary care. And then let's understand that over time, this is one, and there will be iterations of this, and hopefully we will adopt a national standard if we can get to that point. So a lot of complexity. We took an approach where let's just get what we need for this one particular use case, and then continue to talk with our colleagues nationally and with NATO and the APCD Council to get to hopefully a national standard. So I don't know if that's helpful.
Great, thanks, Karynlee. And it's also a kind of a good segue into some of the questions from the audience and our next section, which will be a little more detail about the level of effort around the collection of these data and the investment into data quality and submitter engagement. So Julia, can you briefly describe Civic's process for ensuring data quality? How do you validate the data? How long is the process from start to finish? Maybe a little bit about the back and forth with the submitters.
Yeah, I can try to make this brief, but there's a lot that goes into it. So Colorado we have taken this responsibility to collect high quality data from the submitters very seriously. And we, pretty much it's expected around, like I said, September 30th is when the production files are due. And we are just heads down validating those files and having conversations with carriers. But so the process that we've set up, which is, I believe, similar to Oregon's, or maybe we made it up ourselves. I can't remember where the genesis of that came from, but we collect each year. We originally were going to just do it for the first year, but it's been such a beneficial process going forward that we just continue to do it, which is collecting test files a couple months before the production files are due, validating those files, having conversations with payers, and making sure that they understand that these are the expectations of the file. You know, if they submitted a field incorrectly, or if their numbers don't look quite correct, those are the opportunities for us to have those conversations. And within that validation process, we look at both qualitative and quantitative information. So I'll start with the quantitative. The most basic checks that we do is just comparing what we can against what we have in the Colorado APCD. So we're comparing total claims-based payments that should align really closely with what we have in the Colorado APCD when we aggregate it all up together. So if we're finding that, you know, a payer submits that they only reimbursed $5,000 in an entire year, but the APCD shows they reimbursed $5 million, then there's something going on in one of the files, one of the sources, and we just have to, and then it turns in, a lot of times it's data quality issues within the Colorado APCD that we have to go back and maybe collect resubmissions or something. But so that's a big part of it, is just comparing what we can, so to at least gauge to make sure we're in the right ballpark. But then on top of that, it's these conversations, like I mentioned with the contract supplement, it's having these conversations with the payers and getting the right people on the phone or in the meetings or whatever the form is, to be talking to the right people. A lot of times we're mostly working with the data folks at the organizations, and it's not, as Zachary mentioned before, it's not the contract people, it's not the policy people, it's not the provider relations people who really know the details behind these contracts. So it's making sure that we can translate between, okay, what is the larger concept of what these files or what these contracts look like, and then how do we translate that into what we collect in the files. So we have, with the test files, we have at least 1 hour of conversations with these payers, if not 2 or 3. And then before that, we probably spend 4 or 5 hours just validating for a given payer, just looking at their files, making sure that we understand it. So it's about 5 to 10 hours per payer just for the test file process. And then we do that all again with the production file, which is collected at the end of September, today. So one thing that we've added this year as well, and I know the question about validating the non-claims-based data is a great question, because we don't have that information in the APCD. And what we're going to add this year, which we're very excited about, and I'm sure payers are not super excited about, is we're going to request attestations from the payers. So once we've collected the files, once we've validated them against what we believe to be the correct criteria, once we feel pretty confident that those files are as correct as possible, we're going to send them the results and say, okay, X payer, you have X% of primary care spend, X% of APM spend, X% of non-claims versus claims-based spend. Please sign your name here and say, to the best of your ability, this is as correct of data as possible. Because at the end of the day, the payers know their data better than we do. And that's a way that we're excited to make sure that we engage them a little bit earlier in the process before we've reported on the data and they come back and say, this doesn't look right. Because the last thing we want to do is produce these reports and have policymakers make decisions on incorrect information.
Mm-hmm. Great. So
it's quite a process.
Thanks, Julia. It sounds like you're gonna have your work cut out for you starting tomorrow. So Zachary, similar question. What are you doing to ensure the quality of the data, and how do you validate it? Is it similar to what Julia described, or different?
In some ways, it's similar, but it's different in some key ways. So we also get the data at the same time as Julia. So the data are due today. So if any carriers are out there in Oregon, today is the deadline. And then we take a good couple months to validate it. We don't have a whole lot of validation rules, but we do have some, so we need to process the data that way. And it's almost what I call internal validation, which is to say, if we have one field that says primary care non-claims payments, well, that should be less than the total payments, claims plus non-claims that are in the data. So it's almost like just kind of just pure logic, internal consistency type of validation steps. And sometimes carriers, there's a data element that fails that, and so we have to engage and discuss what's going on. Sometimes it's a valid reason, sometimes it's not. So we do find some errors through those the handful of validation steps we do. One process we also do, we have in the past. Going forward, we probably won't do as often because we're pretty much kind of dialed in. But one thing in the early years that was really helpful was to take the data in, validate it, and then process it for all the ways that Oregon Health Authority is going to analyze it, and then send a summary data table back to the data submitter and say, here's the summary that we've processed. Is this what you meant to submit? There were a number of times in which that initiated great conversation. A lot of, oh, that's how you're going to use the data. Oh, okay, now we understand from stem to stern. We understand the end product. That was invaluable. So I highly recommend any state to think about that. And it's always about engage. I mean, keep your technical advisory group on fast dial or whatever it is. It's really important just to continue to talk about the use cases. What's the end goal of these data? So we've had some pretty good success with that.
Great. Thank you, Zachary. And Karynlee, I think you're probably in the position of maybe other states that are just looking to start this endeavor. What do you think about in listening to both Julia and Zachary respond about the level of effort and the data quality that makes you think about what you might be looking to do once you start receiving these data? Sorry, can't hear you yet.
Sorry, I just made a note to check to see if we are going to a data summary table that you guys just described, which I think we are. But we did build into the rule an attestation. So that is baked into the proposed rule. And I believe 100% that you need to join, this session, this meeting is all about linking policy, right, with data. I also believe firmly that you need to bring together the data submitters with the end user so that there's a clear understanding of how the data that we're all this time into submitting to us is actually being used. And I'll just say something in Maine. There was, and this is a perfect example that aligns with the theme of this conference. There was a bill that was debated in this past legislative session in Maine that was all about increasing the investment in primary care. And it was using the data that we had presented over the last 2 years as the baseline. But the problem is it's understated. And so it's in the payer's best interest to work with us so that what we are reflecting back in terms of primary care spending in the state is a reflection of the true investment in the state, and that the subsequent policy will be based on that, not on a number that is clearly underestimated. So I think that it's full about not just wanting to collect everything for the sake of wanting everything, and instead we really, focus and that focus is based on how we're going to use it, and that the use in some instances are actually in the submitter's best interests. I think we're going to get a better product in the end. But I am a little bit worried. I'm a small team. This is new. So we are going to rely heavily on that attestation. I'll be honest. And we'll see, we'll start to get some experience to see how it all sort of plays out.
Great. Thanks, Karynlee. So we've had a number of really great questions come in. I'm going to start taking a few of them before we move into some more specific discussion on use case. But first question, Douglas McCarthy, payers have expressed concern that state requests for non-claims data don't reflect the way these payments are actually made. How are your states addressing this concern to minimize the burden of data submission and maximize the utility of the data? Who would like to speak on that?
I can jump in with one point, and that is in the early stages when a state is setting up this data collection mechanism, there are a couple decision points that may be helpful that I think touch on Doug's question here. One is what Julia alluded to as one of the key differences between Colorado's approach and Oregon's approach. So Julia uses kind of a residence of the member methodology, if you will, whereas Oregon is using that situs-based approach where if a product is sitused in Oregon, then all the payments for that product are included in the non-claims file, in the payment arrangement file. The reason that connects to Doug's question is because in the early days when we were scoping this out and working with our data submitters, it became pretty clear that they overwhelmingly preferred to use that situs approach because that's how their accounting systems were constructed. And it was significantly easier for them to say, okay, we made this payment as a non-claims payment, and that's associated with this policy. So their internal accounting systems were predicated on situs, whereas their claim system, they could do that membership no problem. And that's what we do for our claims files, for our all payroll claims database. But it's different for our payment arrangement file. So that's just one decision point that a state has to make. And I think it alludes exactly to kind of how the payments are actually made and how carriers even think about these payments.
Great. Thanks, Zachary. Go ahead.
I'll just jump in here. I would just add on to that. Kind of alluding back to what I had mentioned about the contract supplement that we collect. That's an opportunity for us. And we really, I won't say force carriers, but we invite carriers to really have these more detailed conversations. And it's so important to us to get the right people on the phone. And it's just a process, and it's relationship building to make sure that we're able to, the folks at this point, especially because we've just had hours and hours of conversations with some of these carriers, we've gotten to know them pretty well. And we've learned more about, okay, if we have a question related to these capitation payments, this is the person that I need to email at this particular organization, and maybe not the data person, to start having more of those targeted conversations. And we really try to engage the payers as early as possible in terms of when we're making updates to the specifications, and especially, and I'll just bring up the contract supplement that we're just so excited about because it's turned into be just the best way for us to really learn and have more of the conversations that we didn't even expect we needed to have with these payers to really understand the purpose and the intent behind how these payments are paid out. Because a lot of times we say, okay, even though this might be a population-based payment and it sounds like it's a capitation payment, it's actually more like a pay for performance payment. So we need to recategorize this because that's the more of the spirit of what the payment arrangement looks like. But it's high hopes for us to try to figure out how to make sure that these payments get categorized and we're representing this data correctly, but it's a give and take. We're constantly trying to make sure that we have the right conversations and we're representing this data correctly.
Great. So I'll do one last question before we move on to use cases and then some other related questions to that. Sarah Lindbergh asks, curious if anyone has delved into trying to measure non-claims revenue on the provider side. Anybody? This might be a quick one.
In Colorado, a lot of the relationship between for the use case, which I'm sure we'll get to in a minute, a big use case for us is our primary care collaborative through the Division of Insurance. And there's folks on that collaborative who have read our report and said, I'm a provider, this doesn't quite make sense to me, and stuff like, conversations like that. So we've engaged part of the provider community, though there's a lot more opportunity that we have to start engaging that end of the stakeholder spectrum. But a lot more of the conversations are really just validating with the payers and what they're paying out rather than the providers.
Okay, well, maybe that's a good segue. So let's try to understand the use cases for these data. I know that each of you have touched on briefly in some of your introductions and answers, but we'd like to get into some more detail. why you initially wanted to collect these data for, so what was the use case, and how long it took you to get to a place with the data that you were collecting to meet those needs. So Zachary, I'll start with you. How quickly were you able to start making use of these data, and have the use cases and usability improved over time, and any new use cases?
Yeah, it took a couple data submission cycles until all the kinks were worked out. And that's just the reality of it. These are complicated. A lot of times we as the state had to elaborate on specifications because different carriers, different data submitters interpreted it differently. So on both sides, it's a bit of an iterative process. But after a couple of cycles, we were able to kind of almost immediately start to inform policy. As a note, so we started publicly reporting at the market level a year and a half ago or so. And only, I mentioned before, only last week is the first time we're publishing by carrier. In other types of reports, I've found that that level of detail and that level of publication tends to increase the fidelity even more. Because there's comparative analysis that data submitters aren't able to do without that. So I look forward to even greater improvements, but I feel like the data are pretty solid as they are. So one of the earliest use cases was looking at our Medicaid managed care organizations, which we call coordinated care organizations, because we knew we wanted to kind of nudge them towards increasing their use of value-based payments. But we had to understand what the baseline was, and we wanted to really understand, as almost an evaluative effort, how their progress compares to what's going on in the commercial market. And so, are there spillover effects? Are we nudging the Medicaid space in such a way that some of the commercial carriers are starting to increase their use of value-based payments? We can do that now, which is really exciting. And in fact, the very newest use case is the commercial carriers that I mentioned before. They voluntarily signed this value-based payment compact, and they're looking at those more advanced value-based payments, the shared risk, and those capitation payments. So in the coming years, they have kind of self-imposed some targets that they're aspiring towards, and this payment arrangement file will be the data source of record to assess that progress.
Great. Thank you, Zachary. And Karynlee, I'll shift over to you. I know you've alluded to a very specific use case of why you moved to trying to start collecting these data next year. Can you talk a little more about that use case?
So it is an annual report that is required in Maine statute, where we are looking at the data in our all-payer claims data to come up with the amount of total primary care spending in aggregate, and then we break it down by two large publicly funded plans, the state employee health plan and the teachers. And we break out their costs separately. And this report is to our commissioner of the Department of Health and Human Services, as well as the legislative committee that had over insurance and healthcare costs. And again, I think that report was one of the primary drivers, or at least assisted the sponsor of the bill that I was talking about earlier to draft legislation around what investment should be made in primary care, and actually included behavioral health care in the definition of primary care. So I think, there's a lot with collecting the data, but then there's a lot with, like definitions. And I think, to the extent that there's consistency, not only in what we're collecting, but in the definitions of some of these things, if we all define primary care in the same way, or you could go and, find out how states are defining primary care in an easy way, I think that would be really helpful to this overall effort. But in any event, so the lack of the non-claims-based payments that was identified on day one. And so it's taken 2 years to get from that first report submitted, calling out the fact that we didn't have non-claims payment data reflected, that the investment was understated, to where we are now, where we're in the process, and hopefully by the end of this year, as I mentioned earlier, the board will adopt a proposal and we will start collecting it into our 4th year report, which will be in January of 2023. So it's definitely a process. And between now and then, I suspect that there'll be more use cases identified. And that's why I think this is to be an iterative process. I see this, potentially this rule opening up annually as the use cases change and as we get closer to maybe a national standard.
Great, thanks, Karynlee. So, Julia, in Colorado, any unique use cases from what's already been discussed, or future use cases that have been coming up that you'd like to share?
Yeah, I think it sounds like all of our states are very similar in the requirements for primary care reports. So we don't need to beat that horse, though it's a big part of our lives. But it's just becoming more of the conversation with our stakeholders. When I just remember a couple weeks ago, we were sharing a report with our healthcare department that just measured the total spending in different spending categories. Just across for the APCD, just, inpatient, outpatient, et cetera. And she specifically, our executive director of our healthcare department specifically requested that the next iteration of that report will include the non-claims-based spending. And I don't think we're going to be able to report inpatient, outpatient, professional, et cetera, but at the very least, we'll be able to use that data to kind of supplement on top of what's already getting reported in a total cost of care kind of report. So there's a lot of different use cases coming up in the future, but there's limitations because we collected at an aggregated basis. We can't bring it down. I know there's a question in the chat about member level reporting, which there's a lot of hopes that we can make some updates to that, and I'll let you ask a question about that, Leanne. But
I was going right there next. So Carl Finiston had posted a question: non-claims payments most often come in from payers at an aggregated level. For analytics, more granular level is preferred, or the ability to convert to a PMPM. In your experience in trying to develop this data collection, has this issue been discussed with payers?
Yes. Yes. I'll answer really quickly, and I'm sure Zachary has a lot to say, and potentially Karynlee. It's a question that comes up with a lot of our stakeholders. We have no idea how we would collect it based on just the infrastructure of the data collection we have right now. And actually, there was another panel session a couple days ago where we kind of talked about that question. And there's certain payment arrangements where it just does not make sense to be collecting it at a member level to be able to do PMPM analysis. But there's others where it does. If it's a capitation payment and you're paying a provider on a per member per month basis, there's absolutely a way that you could collect that information. We just haven't figured that out yet. But if you have ideas, let us know, because we'd like to.
Anything to add, Zachary?
Just that, as similar to what Julia said, it really depends on which type of value-based payment or APM we're talking about. We've tried to kind of reverse engineer some per member per month spending. We do collect a member month count for some fields. So if there are, Oregon has a primary care home model. We call it patient-centered primary care home, PCH. But it's very similar to the national primary care home model. When a data submitter says they included X number of dollars to this clinic, and they're flagging it as an infrastructure payment, and we actually have a little indicator in our file that it's specifically for a patient-centered primary care home model, we collect the number of member months that are captured in association with that dollar amount. So we can kind of back into the PMPM. We can do that for a couple other examples, but writ large, it is challenging to convert non-claims payments to a PMPM because some non-claims payments are they're just, imagine a payment that a carrier makes to a clinic or a health system to buy an electronic health record. How do you think about that in terms of member months? Sure, you can take total member months that maybe were enrolled in the year, but it just gets a little awkward. That's, to me, completely different than, oh, here's your capitation payment, and it's X dollars times the number of members per month. So some are conducive to it, others aren't, but we try to distill as much as we can in PMPM for those analytic purposes.
Great. So I know I have just a couple more questions. I know we only have 10 minutes left. Let's just switch gears just a little bit. Each of you have talked about how the state is using the data. How are these data available, or are these data available to anyone outside of the state, or will they be?
I can start. Oregon deems these data as trade secret, so they're currently not available to researchers. But we do provide summary data, and we publish that summary data. But when we're talking about a specific dollar amount from a specific payer to a specific recipient, that we flag that as trade secret and don't disclose that.
Okay, and I don't mean great in the sense that's great. It's a very clear answer, but. And Karynlee, how has Maine thought about the release of these data once you begin collecting them?
I got to remember that mic. I think similar to what Zach just said, we have a data release rule, and so at the same time we are pushing through a rule on the collection of this data, we're also revising our data release rule. And I think we would only release these things in the aggregate, or this information in an aggregated way, not identified by payer. But again, I think this is part of the conversation over time. And as we hopefully come together collectively and think about a national standard, is, how should this data be released? And I think that the payers need to be a big part of that conversation.
Great. And that is a segue into my last question, although Julia, anything different in Colorado?
Nope, it's the same.
Nope,
yep.
Just the same. Okay, so last question, and I think John Friedman also posted about this. So the State APCD Advisory Committee, which advised the Secretary of Labor on a national standard data set, discussed the need for a national standard for non-claims payments. Although their report has not yet been published, the members voted to include this recommendation. And this was also my final question for the panelists. Is there an effort So there is an effort underway to create a national standard. What is one piece of advice you have for creating that standard? Julia, do you want to go first?
Just one piece of advice. That's, I think from my perspective, it's just so important to get as many stakeholders in the room as possible to start having those conversations. I'm talking about payers, providers, people who collected the information, who have already collected the information, people who have not collected the information, state agencies, if they're using this, like the audiences of the files that we're already collecting, if it's going to have a major impact, if we change everything, if it's going to have a major impact on how they're measuring and making policy, it's really important to make sure that they're in the room. But, a really good standard is vital, but an evidence-based standard, using the experience of states and other folks who have already collected this it's crucial.
Great. Karynlee, one piece of advice?
I'm going to just say ditto to what Julia just laid out.
Great. Zachary, what do you have to add?
So I'd add that, 10 years ago, if I were to say, I'm investigating payments that are 2C or 3B, you would have no idea what I'm talking about, right? So to that end, the HCP land framework, which isn't perfect, but it's established a common language that I think a lot of people now have. So I'd advise, let's leverage that. Let's leverage that commonality of language and base the standard off of that. Not necessarily it has to perfectly mirror and match the HCP land framework, But just leverage that now common understanding that we have that we didn't have maybe even 5 years ago, 10 years ago.
Great, Zachary.
And to Jill's point, when we launched, the HCP land framework didn't exist yet. So we had our own kind of homegrown categories. This is Jill's question. But we converted. We switched the HCP land category, I want to say 2-3 years ago.
Okay, great. So we still have a couple of last minutes. If people have other questions, there's one that I wanted to touch on in case there was some additional use cases to cover. Kimberly Fox asked, how has Colorado and Oregon used the non-claims-based payment data and specific types of non-claims payments to inform policy or value-based purchasing use cases? I know this came in a little bit ago, but is there anything additional to add that would address this question?
Colorado, similar to Oregon, Colorado, the Division of Insurance is developing regulation. I don't know if it's established yet or not, but regulation to set benchmarks for carriers to increase their investment in primary care and in alternative payment model spending. I don't think we're quite to the point of, we're still honing in our methodology to collect the data, but once that's really honed in, the data collection that we are doing will be the source of information to gauge if that's happening or not.
Great.
The only thing in Oregon, so in the Medicaid space, we do require the CCOs, coordinated care organizations, to achieve a certain percentage, and it's a growing percentage every year, and that's based on those payments that are 2C or higher, so that quality incentive payment or higher. And then there's been some recent discussion for our public employees and our Oregon educators about what types of requirements might they impose on a future RFA for those carriers that are offering those plans. So, a lot more conversations to have there, but I could see these data feeding those requirements in the future.
Great. Well, I really appreciate everyone's contributions to today's panel. I think we're at a really exciting point for the collection of non-claims-based payments and all the work that's gone into getting us to where we are in 2021 with the talk of a national standard and all of these efforts that can go into place to inform this. And I really look forward to hearing additional voices come in over the next few years who have also been able to take the experience that they've heard and that you guys have had to really benefit the field as we move to having the fuller picture of payments. I know that Zachary had a link that he was going to try to share. I think we were going to have somebody post. I think it just got posted, so you can see the reports that they were just released out of Oregon. What timely reports to share with this group. So once again, thanks everyone. I hope you enjoy the rest of the conference. It's the last day and lots of wonderful sessions coming up. Thanks everyone.
Thank you.
Thanks all. Take care.